Hello everyone. Today's topic of discussion is about the plasma cell dyscrasias. So these are the disorders which are characterized by neoplastic proliferation of plasma cells with the production of immunoglobulins. They can be classified into two subgroups, which are of malignant proliferations and can be relatively benign proliferations. So coming to the malignant proliferations, which include multiple myeloma, WALDENSTROM microglobulinemia, plasmacytoma, heavy chain disease, and the relatively benign proliferations include MGUS, MGUS, this is monoclonal gammopathy of undetermined significance, primary systematic amyloidosis, Boehm syndrome. Talking about the malignant proliferations, first of all, we talk about the multiple myeloma. It is a chronic, progressive, and fatal malignant condition which result in lytic bone lesions. M proteins in serum and insufficiency are the main causes of the multiple myeloma. Cell of origin is the antigen exposed post-germinal center B cell with somatic hypermutation, immunoglobulin heavy change in rearrangement and class switching. An early event is chromosomal translocation involving long arm of 14 chromosome 3-2 causing immortalization of the plasma cell clone. This results in the development of MGUS. In almost all the cases, multiple myeloma is preceded by the asymptomatic MGUS. So, plasma cell undergoing translocation of long arm of chromosome 14, resulting in the immortal plasma cell clone production, as a result for 13 chromosome deletion, which results in asymptomatic MGUS, RAS mutation, P16 methylation, mutations in MYC, secondary translocations of P53 mutations, change in marrow microenvironment, ultimately resulting in the multiple myeloma. Bone marrow undergoes changes like increased angiogenesis and overproduction of cytokines and growth factors by stromal cells. These factors contribute to cell growth, survival, and drug resistance. Bone lesions result from imbalance between the activity of osteoblasts and the osteoclasts in multiple myeloma, whereas imbalance of two factors of nuclear factor kappa B ligand or rankle ligand and osteoprotein leads to osteoclast activation and bone resorption. Clinical features: multiple myeloma is a disease of elderly, the median age of presentation being 65 years. Initially, the patient presents with a weakness and weight loss. With the progression of disease symptoms related to the bone lesions, renal disease, marrow failure, and impotence occurrence in the urine. So, bone lesions characterized by pain and tenderness and pathological fractures. Rib skulls, pelvis, scapula, spine, and sternum are the common sites of involvement of the bone lesions in multiple myeloma. Lesion may extend through the cortex of the vertebral body, resulting in nerve root or spinal cord compression. 70 to 75% patients demonstrate the lytic lesions or osteoporosis. Renal disease. Renal failure due to infiltration of myeloma cells into the renal parenchyma along with the blockage of tubules by CAS, which is known as myeloma kidney. So here the renal failure occurs due to the infiltration of the myeloma cells into the renal parenchyma along with the blockage of tubules occurrence, resulting in the CAS formation the kidney, which is known as the myeloma kidney. And Bence-Jones proteinuria. So loss of Bence-Jones proteins in the urine. Marrow failure. Anemia invariably occurs at stem stage as the myeloma cells replace the normal hemopoiesis in the marrow. Increased susceptibility to both gram-positive and negative organisms due to the both decreased production and suboptimal function of the WBCs. M proteins. Hyperviscosity of the M proteins by the M proteins results in affecting the CNS, retina, and CVS. In brain, it leads to confusion and dizziness. Bleeding tendency as the platelets get coated with M proteins, affecting the aggregation, resulting in bleeding. Coagulation abnormalities. M proteins form complexes with factor 5, 7, 8, 1 and 2, affecting coagulation cascade. Amyloidosis. Seen in 5 to 10% of the cases of multiple myeloma. Coming to the laboratory findings, blood picture showing the anemia with progression of the disease and commonly normocytic normochromic anemia. Characteristic feature is Role formation of RBCs with background basophilia due to high globulin levels. Few plasma cells or plasmacyte or lymphocytes may be seen, and a few cases show leukoerythroblastic picture, where in this case the multiple myeloma ESR is very high due to immunoglobulins presence. Bone marrow. The hallmark of myeloma is an increase in monoclonal plasma cells varying from 30 to 90%. The neoplastic cells vary from mature-looking plasma cells to immature plasmablasts. Mature cells, abundant basophilic cytoplasm with a perinuclear area of half, eccentrically placed nucleus with condensed chromatin and no nucleoli. It is a mature plasma cell. Whereas the plasmablasts is a large cells with central nucleus, high NC ratio, fine reticular chromatin, prominent nucleoli without perinuclear half. Cells of intermediate maturation between plasma cells and plasmablasts are also present. Intracellular accumulations of immunoglobulins may produce characteristic morphological features like motile cells, Richard bodies, SL bodies. In few cases, there is secretion of amyloid by plasma cells also seen. So these are about the plasmablasts, the mature plasma cells, which is these are the mature plasma cells. The top left one, which is having the eccentrically placed nucleus with perinuclear half, whereas the below one it is the motile cell, and these are also the immature plasma cells without the perinuclear half on the right top. Urinalysis. Benzone's proteins are free kappa or lambda light chains synthesized by neoplastic plasma cells, which are detected in urine by heat method at 55 degrees centigrade or by electrophoresis in a 24-hour sample. Radiological features. Bone changes include diffuse osteoporosis, localized osteolytic lesions, and pathological fractures. Flat bones are more frequently affected, resulting in punched out lytic lesions without sclerosis at the borders. Biochemical abnormalities. Serum creatinine normal or raised. More commonly, the serum creatinine is raised in multiple myeloma. Hypercalcemia is often present. Serum alkaline phosphatase is most normal or slightly elevated. Monoclonal M protein. Myeloma cells secrete monoclonal immunoglobulin G 60%, immunoglobulin A 20%, and light chains in 50% cases. Electrophoresis show a sharply defined M band, usually in the gamma globulin region. Cytogenetics. With fish, chromosomal abnormalities are identified, and the most common ones are the translocations involving long arm of chromosome 14 and deletions in chromosome 13. Whereas the CD38, the 138, and the cytoplasmic immunoglobulin are positive in case of multiple myeloma, whereas CD19 is negative in contrast to normal plasma cells, which is positive in normal plasma cells. So 38, 138 are positive in case of neoplastic plasma cell in multiple myeloma. Diagnostic criteria for multiple myeloma: presence of M proteins in serum or urine, presence of clonal plasma cells in bone marrow or plasmacytoma on biopsy, presence of related organ or tissue impairment. So, related organ or tissue impairment presence, it can be denoted by the four important aspects such as hypercalcemia, where serum calcium level is more than 11 milligram percentage, renal insufficiency, where serum creatinine is more than 1.96 milligram percentage, anemia less than 10 gram per deciliter, bone lesions, presence of lytic lesions or osteoporosis. So this is, if the four conditions are present, it is related to the presence of related organ or tissue impairment. Staging of multiple myeloma. There is an international staging system of multiple myeloma. Stage 1, where serum beta 2 microglobulin levels are less than 3.5, serum albumin level is more than or equal to 3.5. Stage 2, serum beta 2 microglobulin level is between 3.5 to 5.5, serum albumin level is less than 3.5. Stage 3, serum beta 2 microglobulin level is more than 5.5. Management. By giving the pelflan and prednisolone, this combination induces response in nearly half of the patients. Thalidomide blocks the ability of VEGF and FGF to induce angiogenesis of the marrow. Also inhibits interleukin 6 and tumor necrosis factor alpha and growth and survival of myeloma cells. Proteasome inhibitors. Proteasome inhibition leads to induction of apoptosis and increased sensitivity to radiation and chemotherapy. Bisphosphonates inhibit osteoclast-mediated bone desorption. Inhibition of interleukin 6. Strategies of neutralization of interleukin 6 and blockage of its receptors is under study. Marrow transplantation. Autologous peripheral blood stem cell transplantation is recommended for cases which do not respond to conventional chemotherapy. WALDENSTROM macroglobulinemia. It is an uncommon B-cell neoplasm which is characterized by lymphoplasmacytic cell proliferation in the marrow with secretion of IgM paraproteins. It is a disease of elderly with peak incidence between 60 to 70 years, more commonly seen in males. Clinical features: anemia is mild to moderate. Hepatosplenomegaly and lymphadenopathy seen in later phases due to infiltration by the neoplastic cells. Hyperviscosity occurs when serum viscosity is 4 times normal. Visual impairment due to retinal hemorrhages and X-rays formation. Bleeding tendencies resulting in peripheral epistaxis. Neurological changes such as headache, ataxia, vertigo, altered mental state, and coma can be seen in WALDENSTROM macroglobulinemia condition. Uncommon manifestations include these. Laboratory findings: on CBP, normocytic normogrammic anemia with characteristic Golgi formation, leukopenia with lymphocytosis, platelets are normal or decreased, ESR is elevated, bone marrow is infiltrated by lymphoplasmacytoid cells with few mature lymphocytes and plasma cells. Plioma. Next, lymphoplasmacytoid cells also infiltrate nodes, liver, and spleen. Benzone proteinuria is seen in 50 to 80% cases, but no nephropathy. Immunophenotyping: CD19, 20, 22 are positive, CD5, 10, 23 are negative. Protein electrophoresis: discrete M band in beta or gamma globulin region. Immunoelectrophoresis confirms its IgM nature. Treatment: therapy is initiated to patients developing symptoms. Plasmapheresis with 50% of total plasma exchange is beneficial in cases with hyperviscosity syndrome. The commonly used chemotherapeutic drugs are chlorambucil, which is an alkylizing agent, rituximab, which is a monoclonal antibody against CD20, bortezomib, which is a proteasome inhibitor. Coming to a condition that is plasmacytoma. It is a rare disorder in which renoplastic proliferation of plasma cells is limited to a single focus in the bone composed of plasma cells. Here the patient presents with a bone pain or pathological fractures at the lesion. Common sites are involving are these. Regular follow-up with urine and serum electrophoresis is essential. A few patients are cured after 10 years or develop recurrence, but most patients develop disseminated disease, which is the multiple myeloma. Then a condition called as heavy chain disease. Alpha heavy chain disease, also known as Seligman's disease, the commonest form of heavy chain disease. The lamina propria of the small intestine is infiltrated by lymphoplasmacytoid cells that secrete alpha chains. The patients manifest with chronic diarrhea, weight loss, malabsorption, and mesenteric lymphadenopathy. Gamma heavy chain disease, also known as Franklin's disease. There is secretion of gamma heavy chains. There is nerve involvement of the Waldenström ring resulting in palatal edema and respiratory compromise. These patients have lymphadenopathy, fever, anemia, and malaise. They have a rapid downhill course. Monoclonal gammopathy of uncertain significance. It affects the 2% of elderly over 50 years with increasing incidence with age. Diagnostic criteria of MGUS: serum monoclonal proteins less than 3 gram per deciliter, bone marrow plasma cells less than 10%, no evidence of other B-cell proliferative disorders, no related organ or tissue impairment. Follow-up of these cases is necessary as there is a chance of about 1% per year to evolve into malignant disorders. Remember, the difference between the multiple myeloma and MGUS is main difference. There is in multiple myeloma there is presence of relative organ or tissue impairment, whereas in MGUS there is no relative organ or tissue impairment. That is, the CRAB criteria is present in case of multiple myeloma. There is no CRAB criteria in case of molecular gammopathy of uncertain significance. What is CRAB criteria? Hypercalcemia, renal insufficiency, and bone lesions. Primary systemic amyloidosis. Paraproteins are detected in 90% patients with primary amyloidosis. They have no radiological or histological evidence of myeloma or macroglobulinemia, although the organ distribution resembles that of myeloma-associated amyloidosis. In both myeloma and amyloidosis, the amyloid protein is derived from light chains. Chemotherapy with similar agents as in myeloma has been reported to halt the progression and produce partial recovery in amyloidosis. Coming to the POEMS syndrome. POEMS syndrome, it is abbreviated as polyneuropathy or organomegaly, endocrinopathy, M protein, skin changes presence. So polyneuropathy, sensory and motor type, organomegaly, which includes spleno, hepato, and lymphadenopathy. Endocrinopathy, which includes presence of hypothyroidism, Addison's disease, and early gonadal failure. M protein, which includes IgG type M protein with lambda light chains. Skin changes, which include the skin thickening resembling scleroderma, hypertrichosis, hyperpigmentation, Raynaud's phenomena. So the POEM syndrome, which is abbreviated as polyneuropathy, organomegaly, endocrinopathy, M protein presence, and skin changes. POEM syndrome is observed in rare cases of osteosclerotic multiple myeloma, where presence of increased dose of pro-inflammatory mediators are seen, like interleukin-1, 6, VEGF, and TNF-alpha observed. This condition is associated with pulmonary hypertension and restrictive lung disease, and POEM syndrome individuals present with good prognosis. Thank you.